So today we are going to talk about leukocyte adhesion deficiency. And leukocyte adhesion deficiencies are of two types: leukocyte adhesion deficiency type 1 and type 2. Uh, at first, to understand this leukocyte adhesion deficiency, we need to understand how does leukocytes extravasate. Here leukocyte means, let's wrap it up. Leukocyte extravasation we have seen here. This is generally, we need to know this step of extravasation in order to understand what they are talking about leukocyte adhesion deficiency. In leukocyte extravasation, it generally occurs in the postcapillary venules. Remember this thing, number one thing you need to know. And there are two circulating pools of neutrophil. One is like something that is attached to the endothelium and something that is circulating the neutrophil. When we do CBC, we just see the circulating pool. Okay. The steps we need to know: 1, 2, 3, and 4. There are in total 4 steps. The first step is margination and rolling. Second is tight binding. Third is diapedesis, and fourth is transmigration. In margination and rolling, if it is defective somehow due to decreased expression of the sialyl Lewis X, sialyl Lewis X is on the leukocytes we have seen, which is attached to E-selectin and P-selectin respectively on the endothelium. Tight binding, we have seen it's defective in leukocyte adhesion deficiency type 1. There is a decreased expression of CD18 integrin subunit. The integrins are on the leukocyte surface, and in the vasculature we would have ICAM or VCAM. You don't have to remember this 1 or glycam 1 or stuff like this. Don't think about the numbers. It's low yield. Then with diapedesis, there is WBC, which travels between the endothelial cells and exceeds the blood vessel. Now, for diapedesis, it's pretty easy to remember. In both vasculature or stroma and on the leukocytes, we would see what? PCAM1, PCAM1. Okay. Now this CD34, it's also known as glycam1, which is on the vasculature or stroma, which is attached to L-selectin on the leukocytes. Generally, L-selectin is for the lymphocytes, E-selectin is for the endothelium, P-selectin is for the polymorphonuclear leukocytes. Generally, this is for the P-selectins are on the stroma. Generally, they are on the endothelium. Okay. This CAM, whatever you are seeing, this CAM are generally like carbohydrate molecules. The sialyl Lewis are some sort of carbohydrate molecules as well. What we see here for migration, which is also known as transmigration, or you can say chemoattraction. Sorry, transmigration is generally diapedesis. Migration is due to chemoattractant products, which are like 5. We need to remember always. These 5 are what? C5a, interleukin 8, leukotriene B4, kallikrein, and platelet activating factor. Remember this thing. Very, very, very important. Let's see the process. First, it's margination. It's marginated and bound to E-selectin or P-selectin. Sialyl Lewis X is on the surface of the PMN. If this one is defective, it's leukocyte adhesion deficiency type 2. This LFA1 is also known as integrin. This LFA1, if it is defective somehow, if we see, if it is defective or decreased, that is LAD1. Remember this thing. Okay, and firstly, margination and rolling is some sort of loose attachment. Tight binding is like tight. Tight binding is generally done with the help of integrins and like the ICAM or VCAM, as we have seen here. This integrins, ICAM, VCAM, these are like tight binding. And for margination and rolling, it's generally the selectin molecules, which are like transient attachments. Selectins are transient attachment molecules. Transient attachment molecules, selectins. Okay, then we can see here like the diapedesis, the migration. Okay, we have to know something else about them. monoclonal antibody against the alpha 1, sorry, it's like alpha 4, against the alpha 4 subunit of the integrin, and it's used in multiple sclerosis. It's a promising target, promising drug against multiple sclerosis. Need to know is like this thing. This thing is gonna pop up several times, even in the UWorld or whatever you say. You'll find that there's some collagen attachment with it is fibronectin, and with it is attached this thing we are talking about, integrin. Integrin spans from the extracellular membrane to the intracellular membrane. Okay, now integrin is calcium dependent, definitely. Another one which is calcium dependent is cadherin. Okay. Another thing we can talk about is another higher clinical topic you need to know, which is an integrated topic. Because the USMLE questions, they're more of like an integrated style. They would ask you like this CD34 or this CD31, where are they expressed? Remember, this CD34 is expressed in Kaposi sarcoma, CD31 in hepatic angiosarcoma. And how would they question you about this? What would they ask you? Like a patient came with right upper quadrant pain for 3 months. On examination, he has icterus, hepatomegaly, altered liver function test, on CT scan a hepatic mass. Remember this, mass. Whenever they're talking about a mass and you see all these vessels out here, what would it pop up in your mind? Hepatic angiosarcoma. And you answer the marker CD31. If you know it, it's a free point. That's it. Okay, here we are talking about a question. Let's solve the question. Here we are seeing like a 2-year-old child who has suffered, question number 17. It's from immunology practice questions from the Kaplan 2019 immunology section. We can see a 2-year-old child who has suffered recurrent bacterial infection is evaluated for immunologic deficiency. The child has age normal numbers of CD19 and CD3+ in the peripheral blood and extreme neutrophilia. Remember this thing. Few points you need to remember. Neutrophilia is there. A lot of neutrophilia is there. It's CD19 positive, which is a marker of B cell, right? CD3 positive. Okay, fine. CD3 is found in the lymphocytes. It can be found on T lymphocytes generally. Okay. The nitro-blue tetrazolium dye reduction test is normal. What is the most likely defect they are talking about? Okay, let's talk about this thing. This CCR4, it's located on the macrophages, okay, and on monocytes. So if there is an absence of CCR4, what will happen? If there is an absence of CCR4, what will happen? An absence of CCR4 would imply there would be an extravasation problem of the macrophages and monocytes. Okay. If there is an absence of interleukin 1, which is produced like from the, it's a part of like Th1 cell, interleukin 1/6 and TNF alpha, it would be generally asymptomatic. If there is an absence of interleukin 4, what would happen? Well, interleukin 4 activates what? Th2 cells. So there would be problem with Th2 cell stuffs, whatever there are on the Th2 cells. With interleukin 1, it might cause difficulties in producing an acute and chronic inflammatory response. So what would it cause? Interleukin 1. Interleukin 1 would cause problems with acute and chronic inflammatory response. Okay. Interleukin 4, interleukin 1 is associated, like generally it is an endogenous pyrogen and it produces fever. So it's generally redundant. It's generally redundant without interleukin 6 and TNF alpha. So generally the patient would be asymptomatic. Okay. Okay. Interleukin 4. It's like generally interleukin 4 is associated with Th2, which generates like immunoglobulin E. So if somebody has a deficiency in interleukin 4, they would like lack, and they would lack like immunoglobulin E production. Okay. If somebody has problem with TNF alpha, well, this is also a pro-inflammatory cytokine associated with interleukin 1 and stuff. So if TNF alpha is reduced or absent, what will happen? The patient would be asymptomatic as well. So CD18, which was the option, that is the answer. Why? Because CD18 deficiency, we know it is associated with leukocyte adhesion, it is associated with leukocyte adhesion deficiency type 1. It is associated with leukocyte adhesion deficiency type 1. What are the cardinal features? Well, they would present with delayed separation. It's not only LED1, all the kinds of LEDs, they would present with delayed separation of umbilicus, which is also known as omphalitis. Well, except that, what can it do? What can it cause? Leukocyte adhesion deficiency. This is the cardinal sign. This is the cardinal sign of leukocyte adhesion deficiency. Whatever it is, let it be LED1 or LED2. Well, this one you can find it on the Kaplan. What you will find it there is leukocyte adhesion deficiency is an autosomal recessive disease. It is mostly due to the CD18, and it's a beta 2 chain of the number of integrin molecules they have talked about. Well, what are the first thing that you would see? The first indication of this defect is omphalitis, and it's a swelling and reddening around the stalk of the umbilical cord. Okay, then the patients are no more susceptible to viral infection and than are normal controls, but they suffer recurrent chronic bacterial infections. So with leukocyte adhesion deficiency, you have no viral infection, okay, but you will have chronic bacterial infections. Okay, then with leukocyte adhesion deficiency, they have high number of granulocytes in their circulation, but the migration into the sites of the infection is not possible. Okay, so abscess and pus formation do not occur. Very, very important. You won't have any formation of abscess or pus. One method for diagnosing LAD or leukocyte adhesion deficiency involves evaluating expression or lack of beta chain CD18 of the integrin. And how do you diagnose it? With the help of flow cytometry. Very important. Bacterial infections in leukocyte adhesion deficiency can be treated with antibiotics. So how do you treat it? With antibiotics. If a suitable bone marrow donor can be found, the hematopoietic system of the patient is destroyed and cytotoxic chemicals in the bone marrow transplant is performed. Okay. Let's see into some of the chemoattractant molecules we have talked about a few minutes back. These are the chemoattractant molecules. Okay, we have talked about the chemoattractant molecules. So here we can see the chemoattractant molecules chart from the Kaplan Immunology. They have talked there about interleukin 8, the origin of interleukin 8 is from the tissue mast cells, platelets, neutrophils, okay, monocytes, macrophages, eosinophils, basophils, lymphocytes. So almost everything, whatever you're seeing here. Complement split product C5a, where does it come from? It comes from classical or the alternative pathways. Okay, so for the leukotriene B4, we are seeing the membrane phospholipids of macrophages, monocytes, neutrophils, mast cells from the arachidonic acid cascade, which is the lipooxygenase pathway. Do you remember there was this one COX pathway and the lipooxygenase pathway? Formal methionine peptides, it's released from the microorganisms. Generally, this formal methionine peptides, these are used for initiation of translation. Remember this thing. These are used for initiation of translation. Sorry if you can see it. This is initiation of translation. Okay. Formal methionine peptides, these are used for initiation of translation. The question here came, like a patient came with right upper quadrant pain for 3 months. On examination he has icterus, hepatomegaly, altered liver function test. On CT scan a hepatic mass is found. A partial lobectomy is performed and a biopsy was done. What is the marker they are asking? CD45, 31, CD8 or CD15? Well, what we see here is like there is a blood vessel, definitely there is blood, and most probably it is a vessel. And think about it, like on a liver there are a lot of vessels, definitely, but there's one big vessel. What does it imply? It implies mostly hepatic angiosarcoma, which is very common. And generally this hepatic angiosarcoma, generally what do they do? Due to this angiosarcoma, there is a proliferation of a lot of lymphocytes all around it. Since there is a lot of lymphocytes proliferating all around, how do they came here? And hepatic angiosarcoma, they express this CD31 marker. If they ask you like what is the CD34 marker, see here we are seeing CD34, right? CD34 is associated with, like on the corresponding endothelium we have CD34, and on the leukocytes we have L-selectin. This CD34, you have to remember one thing about it as well. CD34 is a marker for Kaposi sarcoma. Remember this. CD34 is a marker for Kaposi sarcoma. So we can keep a note out here. It's associated with Kaposi sarcoma. And this CD31, it's associated with hepatic angiosarcoma. I hope you can see what I'm writing out here. It's so small, it's pretty minute, but I'm trying.